Good evening and welcome back to the Lipid panel. My name is Dr. Merle Myerson. I'm co-chair of the programming for the Lipid panel, working alongside with Dr. Guy Mintz and our NLA liaison, Amanda Hicks, known as Mandy. The Lipid panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, Lipid conference is a great way to debrief after busy clinic, to review diagnostic approaches, how to interpret clinical findings and generate therapeutic strategies, and to come together with colleagues. For the rest of us who feel like we're on lipid islands, conferences like this remind you that you are not alone. If you have cases that you want to be presented at a future conference, please email Mandy, that's at ahicks, H-I-C-K-S, at lipid.org with your suggestions. We'd like to involve people from all of our chapters as well as trainees. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions, and we will try to cover as many important clinical topics every lipid specialist needs to know. This series is meant to be a monthly coming together of rising stars like NLA lipid scholars and early career lipid specialists with more experienced colleagues. Look for our schedule posting for final Tuesday every month. Tonight is an exception due to the holidays. This will be our last lipid panel for the year, actually, and we will resume again in January. So tonight I'm joined by a superb panel. Our case presenter is Mariana Henry, who is a fourth-year medical student at Geisel School of Medicine at Dartmouth. She's currently applying to internal medicine residency. She studied nutrition science at UC Davis and then earned a Master of Public Health in Chronic Disease Epidemiology at Yale University. And our moderator is Dr. Kevin Maki. We all know him well. He's the most recent past president of the National Lipid Association. He is chief scientist at Midwest Biomedical Research and an adjunct professor, Dean's Eminent Scholar at Indiana University School of Public Health. He is also our co-editor-in-chief of the NLA Journal of Clinical Lipidology. Our two discussants are Carol Kirkpatrick, who is a clinical scientist at Midwest Biomedical Research and an adjunct faculty at Kasika Division of Health Sciences, Idaho State University. So you probably also know her for all her work in, she's a registered dietitian, nutritionist, and a clinical lipid specialist. Our other discussant is Dr. Gregg, who is a National Lipid Association lipid specialist, also a specialist in cardiometabolic disease and women's menopausal health. He is an assistant professor of general internal medicine at Johns Hopkins University School of Medicine, a diplomat of the American Board of Clinical Lipidology, and fellow of the American College of Physicians, NLA, and American Society for Preventive Cardiology. He works as the director of the Baltimore Lipid Center in Towson, Maryland. So with that, I'm going to turn our program over to our moderator, Dr. Maki, and welcome all to the lipid panel. Dr. Maki, it's all yours.
Okay, thank you for that kind introduction. And Dr. Kirkpatrick, if I could have the next slide, I'm going to start with a little bit of groundwork before I turn things over to Mariana to present the case. I wanted to bring to your attention three statements that have recently been released, one from the American Association of Clinical Endocrinologists, one from the American Association for the Study of Liver Disease, and one from the American Heart Association, that all deal with non-alcoholic fatty liver disease and non-alcoholic steatohepatosis. And so we'll be talking about the case and discussing what the guidelines are recommending for management of the case that we'll be discussing this evening. And the next slide. So just as a little bit of groundwork, On the left there, you see a figure of a normal liver with less than 5% of lipid in the hepatocytes. And as a normal liver progresses to non-alcoholic fatty liver with more than or greater than or equal to 5% fat in the hepatocytes, then it can further progress to non-alcoholic steatohepatitis, and that involves inflammation, ballooning of the hepatocytes, and fibrosis. And as NASH progresses, the fibrosis in particular progresses and can ultimately lead to cirrhosis and eventually, in some instances, carcinoma. And so the objectives with regard to the liver are to arrest or reverse that progression from NAFLD to NASH to cirrhosis potentially. And if we go to the next slide, there has recently been a set of recommendations regarding updating terminology. Now, we're generally going to stick with the older terminology of NAFLD and NASH, but the new recommended terminology has come out just recently, and the terms non-alcoholic and fatty were felt to be stigmatizing, and so new terms have been recommended. For NAFLD, the new term is metabolic dysfunction associated steatotic liver disease, or MASLD, and the new term for NASH is metabolic dysfunction associated steatohepatitis, or MASH. And so we generally won't be using this terminology, but because it's going to be coming out in publications in the future, we wanted you to be aware of that. There's also another new category called MET-ALD, and that is metabolic and alcohol-associated liver disease. And that refers to someone who has liver disease, either MASH or MASLD, that is also associated with excessive alcohol intake. And for women, that would be defined as at least 10 servings of alcoholic beverages per week, and for males, at least 15 servings per week. If we can go to the next slide. And so with that background, I'll turn the floor over to Mariana, who's going to tell us about this case. And as we progress through the case, there will be some questions that we'll turn over to the panel members to discuss. And then in addition, as we go through the presentation this evening, we'll be accepting questions from participants or audience members, and we'll address those questions along the way as well. So Mariana, the floor is yours.
Yeah, thank you, Dr. Maki. So for the patient case, this is a 67-year-old non-Hispanic white male. He presents to the lipid clinic for diabetes follow-up and atherogenic dyslipidemia. His medical history is significant for type 2 diabetes, hypertension, a 20-pack-year smoking history, and he quit 10 years ago. He has no previous atherosclerotic cardiovascular disease events, and his physical exam is notable for abdominal obesity. It's otherwise normal. Next slide. For his nutrition and dietary history, he has received nutrition and diabetes education in the past. He reports not following any particular dietary pattern at present. He consumes 2 to 3 servings of alcoholic beverages per week. His physical activity history is notable for walking 30 minutes, 3 to 4 times a week. Next slide. For his current medications, he takes metformin 750 milligrams, extended release BID, rosuvastatin 20 milligrams, ezetimibe 10 milligrams, aspirin 81 milligrams a day, losartan 100 milligrams a day. His vital signs are notable for a blood pressure of 120/78, a pulse of 76, a weight of 230 pounds, and a height of 70 inches for a BMI of 33 kilograms over meter squared. For his lipid panel, he had a total cholesterol of 189 milligrams per deciliters, LDL of 79, triglycerides of 331, HDL of 44, a non-HDL cholesterol of 145, an ApoB of 80. his metabolic and LFT profile, he had a hemoglobin A1C of 7.6, an AST of 98, an ALT of 87. Based on moderate risk profile, an advanced carotid femoral plaque scan was performed, and the results were significant for bilateral femoral plaques. So based on the patient's current lab values, what would be your next step for determining whether this patient had NAFLD or NASH, or MASLD or MASH?
Great. So Mariana, maybe you can start and let us know what your initial thoughts would be in a patient like this. What would you think the next step would be?
Right. If you could go back to the slides, yeah, let's see. For the first part, I would just start with reviewing the labs with the patient and seeing, just hear from him first and see how everything's going with his activity, his diet, and if there's any family history of any liver diseases that we should know of. And if you could go back to the slide before where we talked about habits. Thank you. Yeah, and just confirm with the alcoholic history and see if there's any other signs of alcohol use. Because I know we talked in the physical exam that he just has the abdominal obesity, but there could be other things that we're missing.
Great. In terms of next steps relating specifically to liver health, what would be the next thing that you would do in terms of deciding, is this someone who needs additional testing to evaluate liver health? And I think we can go to the next slide, which.
Right.
Ta-da.
Yes. So the American Association for the Study of Liver Diseases recommends clinical decision aids to identify patients at low or high risk for advanced fibrosis. So some of the tools include the NAFLD fibrosis score, vibration-controlled transient elastography, or the FIB-4 index. And the FIB-4 index is a score based on patient age, AST, ALT, and platelet count. The utility would be to rule out patients at low risk of advanced fibrosis from unnecessary specialized care and determine which patients need additional assessment. So as far as the interpretation, a score of less than 1.3 is compatible with the absence of advanced fibrosis. 1.3 to 2.67 would be an indeterminate result. And then greater than 2.67 is compatible with the presence of advanced fibrosis. So which patients should receive the FIB-4 index? Those would be patients with insulin resistance, prediabetes, and type 2 diabetes. You would also look at for those patients with metabolic syndrome components, and then liver enzymes elevated. You'd also consider it for patients with a BMI greater than 30, and then fatty liver identified via imaging.
So I have a
Great.
quick question before we move on, Kevin, if that's okay.
Sure thing.
Kind of going back to our previous slide, I just wanted to see, in addition to what Mariana pointed out, if Gregg, before doing, say, a FibroScan or a FIB-4, is there something that you would be looking for before you took this step with this case?
Some of you may recognize this case from the lipid spin. This is actually my patient, and what we left out is important, I think, and that is that the liver function tests are chronically elevated. So you might, when you see these elevated liver function tests, you want to see, could this be an acute infection? Could it be, there's many things that can elevate liver function tests. So in somebody with a kind of dysmetabolic history like this, who has chronically elevated liver function tests. So that's one bit of information. I do a largely consultation service, so I have a lot of old records on some of these patients, and we can go back and see the persistence of the LFT elevation. So that's one thing, that I would want to point out here. I think the FIB-4 is certainly, one of the best options for the first tests to do. And I can talk about that a bit. I don't know if anyone else on the panel has done a lot of these, but I've done tons and tons of FIB-4 tests. So is this a good time to talk about it a little bit, Kevin?
Sure. Why don't we talk about FIB-4 and then based on the results, we can talk about what's the next step after
Sure.
the FIB4 results.
Yeah.
So maybe we can just flip to the next slide to show this patient's FIB4. And so, Gregg, please continue.
Yeah. So the FIB4 test is very interesting, and then it's a test where you're basically trying to look at the degree of fibrosis that the patient has, serious liver disease beyond just the simple fatty liver disease. And the test has a very high negative predictive value. So when you're in the green zone, can you go back one more, Kevin? Go back, because I love visuals like this. I use a lab similar to this. It's very colorful. When you're in that green zone, the negative predictive value for severe liver disease, meaning fibrosis, is about 95%. So if you're in the green zone, fantastic. If you're in the red zone, we got a big problem. We almost certainly have advanced fibrosis. So unfortunately, you get a lot of patients in the yellow zone, including me. When I did this test on myself, I think I was 1.31, Kevin, I'm afraid to say. But here's the kicker. So the test is very, it's not very sensitive in young patients. This is not a young patient. So if we did this on Mariana, the test is not going to be that sensitive. Sorry, you're the only young person I can see there, Mariana. So, and if we do it in an older guy like me, 66 and a half, the test above 65 becomes less specific. So my strategy is, depending upon how, I'm feeling about the patient, how, and it's just a gut feeling from seeing these patients. I'm going to, with an indeterminate result, I'm almost always going to go on to another further imaging type test, such as a FibroScan, which we can talk about in a minute. But the other point to make about FIB4 is FIB4 correlates very well with a lot of bad things that happen to our patients. It correlates with cardiovascular disease, with CKD. It correlates with mortality when the score is high, hepatocellular carcinoma. So it's, as we move into this stage where we're looking at cardiometabolic disease, we're looking at, the arteries, the lipids, the kidneys, the liver, the pancreas, as we're looking at all this together. This is a very, interesting and useful tool that I use a very small EMR in my practice because it's small, but I think more and more EMRs are starting to incorporate FIB4 testing. It costs next to nothing, as you could see what the components are. I don't remember my calculus from high school, Kevin, you may, but there's a interesting little figure there above the ALT, but it's very easy. There are online calculators to do it. If you don't have access to it, you can do your own FIB4, very easily. Just Google FIB4, and there's plenty of online calculators where you can get that.
And maybe I'll ask one additional question, because in this case, the next step was to do elastography.
Right.
So to run a FibroScan, which is a brand name. And,
yeah, sorry,
but that's how people know it in the medical
It's like
community.
Xerox, right?
Yeah,
right.
exactly.
Right.
So, what would be the other imaging options that might be considered if, let's say, somebody doesn't have ready access to a FibroScan?
Well, you could certainly do regular abdominal ultrasound, and I didn't want to go too far down this rabbit hole, but when we did our carotid femoral plaque scan, which we're obviously focusing on the carotids and the femorals, we also take a peek in the abdomen. And this guy, from my recollection, did not have any significant fatty liver. Now, you'll see terms like, I work a lot with my ultrasound tech together. He'll use terms like fatty liver with preserved penetrability. And so you may run across that when you're doing an abdominal ultrasound. And that means that there's not much fat in the liver, or the amount of fat is low, maybe less than 30%, something like that. Whereas he'll often say with increased, we'll say decreased penetrability. When you have a lot of fat in the liver, it blocks the ultrasound, so you don't get the same translucence, et cetera. So these are terms you'll see. You could do a CAT scan. A CAT scans, you could do MRIs, there are other imaging techniques, but the ultrasound, the abdominal ultrasound, is probably the simplest technique that a lot of us are familiar with.
Great. And Dr. Kirkpatrick, would you like to comment on the results we've seen so far?
Well, I just wanted to ask Greg, because you mentioned that you would, your patient had this history of elevated LFTs. So that would be one of the things you would look for to
Right.
determine doing the fiber scan or the FIB4. So would the patient's history of having, excess adiposity, especially the abdominal obesity, be also something that would trigger you to want to find out more? And then would you be concerned about his elevated LFTs because he's on a statin as well? What are your thoughts about that? And Mariana,
Yeah,
free to share as well.
absolutely. So, yeah, the more dysmetabolic somebody is, the more I'm going to be concerned with doing a FIB4, and the more I'm going to be concerned about fatty liver disease. As you can see in the list of patients who should get this test, you've got insulin resistance, prediabetes, you've got all that in there.
So
And
really,
one of
the
my
patient fits all of that criteria.
yes, right, the 100%. Except he didn't have fatty liver identified on imaging. That was kind of
Good
interesting.
point.
You never want to put all your eggs in one basket, right? I mean, that's and the thing with the statins, so we can maybe come back to that later when we talk about therapy, but one of the most common consults we get as lipidologists is the function tests are up, patients on a statin, or I'm thinking about starting a statin. What do we do? And certainly the statins could be playing a role in that liver function test elevation. Absolutely. But as we'll find out later, I think we'll have an opportunity to do this. Statins have a very important role in decreasing the number one reason why these people die, which is a cardiovascular event. So,
Exactly.
one of my themes is don't stop the statin. Maybe we're going to cut it back. Maybe we'll switch statins. Maybe we'll, but don't stop the statin in these people.
Great.
Very good point. So maybe we can go to the next slide, or actually 2 slides forward, I believe.
I'm frozen. There we go.
Oh,
There we go.
Yeah.
And so a fiber scan was done. And so Mariana, what are your thoughts about these fiber scan results?
Yeah, so the fiber scan was done and the results were notable for stage S3, severe steatosis, and stage F1, minimal fibrosis. And if you could go back, we had the score that we didn't go over. Sorry.
For
Oh, yes, the FIB4 score was 1.67.
Yeah.
So what's next?
and that's where the patient had the fiber scan done.
Right.
Mhm.
I'll tell you
And
guys one of the ways that I explain this to patients when we see this. I say, look, imagine you're in Ruth Chris and you just got a nice steak, and the majority of the steak is fat. That's what it means when you have severe steatosis. I don't think it doesn't sound too appetizing, does it? I mean, we're talking, significantly more than 50% of the liver is fat. Obviously, that is not good. The good news here is we don't have a lot of fibrosis. So this looks like something that is potentially very reversible. We send this patient to our dietitian, as did happen in my practice. We have a dietitian associated with us. Now, this looks like something that we can fix. That's the good news here.
yeah, and so maybe we can go to the next slide and start talking about, okay, what do we do with this patient? So objectives of therapy. And so, Gregg, maybe you can comment on what are the key objectives with a patient like this? What are you trying to accomplish clinically?
Well, I have to say, Kevin, first thing I'm going to do with this patient is send him to Carol. So I just want to make that clear. Okay. But my objectives are to reduce the number one killer of these patients, which is cardiovascular disease. So we're going to make, as you can see, his ApoB was pretty reasonably lowered. We could, that's probably another discussion where we want it to be given his subclinical disease. But the number one priority is to realize that this is a higher risk patient for a cardiovascular event. Number two, we want to stop the progression of the steatosis before this leads to fibrosis. The more steatosis you have, the higher your risk for fibrosis. So those are my two objectives.
Great. So with regard to lowering cardiovascular risk, of course, you want to address all of the modifiable risk factors. And so what would your objective be with regard to where would you like to see the LDL cholesterol level, the non-HDL cholesterol level, blood pressure, and A1C?
So this guy has evidence of subclinical disease by the carotid femoral plaque chain. He's actually got bilateral femoral significant plaques. So that I work with Dr. Tom Barringer on this. That means, based upon the studies that we cite, he's got about a 4-fold increased risk. So he's got significant subclinical disease compared with someone who doesn't have any bilateral femoral plaques. Also, he's got diabetes, so, we would consider this guy to be a CHD risk equivalent under old style guidelines. Now we know there's potentially a gradient of risk even within diabetics, but I would say his LDL cholesterol has got to be at least less than 70. I mean, he would fall into that bucket, in my practice. And you might even argue for lower based on the subclinical disease. So he's not, I don't remember what his LDL cholesterol was. I'm more ApoB focused.
It was 79.
79, yeah. So he could use some additional work, on that.
And I'll point out that his non-HDL cholesterol was 145.
Right.
Where would you like to see that?
Yeah.
31. Yep.
Right. Since we're gonna, I would want that to be less than 100.
Right.
Yeah.
So
some
work to do there.
Yeah,
yes,
sure.
absolutely. We would want his hemoglobin A1C to be under 7. We'd like his blood pressure to be at least less than 130/80. I forget what other parameters we'd like to get his exercise level up. Obviously, that's more of a therapy than a. I don't remember what else you had asked, Kevin. Sorry, that was.
Sure thing. So, the big risk factors: lipids, blood pressure, and diabetes control.
Right. There we go.
And the first step is always lifestyle. So, Carol, do you want to talk about what would be done in terms of lifestyle? And I think that's the next point here. What would you suggest?
First, I apologize. I have a little lag with my slide advancing. So, but I want to just reiterate what Mariana already mentioned a few slides ago, and that definitely would take a few minutes to find out what's going on with the patient already. So clearly the nutrition history, he's had some diabetes education and some nutrition education in the past. I'd want to find out more about, what did he still have retained from that? He's not following a dietary pattern? I would like to find out why. Did something turn him off in the past for that? And then with his physical activity, he's walking at least, definitely not, at the minimum 150 minutes per week at this point, but find out kind of where he's been, his past history, why he's not following a dietary pattern, kind of see where he is now, meet him where he is now. Give him kudos about being physically active, because that is, a place to start. So kind of start there. And then, all the things we talked about, the only thing that was really already where it should be is his blood pressure. It was 120/78, I believe. So we have definitely work to do on reducing his triglyceride level. His LDL-C is not too far off. I think most of us are aware that nutrition wise, we can focus on limiting foods that might increase that LDL-C, but probably statin therapy is going to be effective with that. Although he's just got a little bit to go. So, maybe if we tweaked his nutrition a little bit, that would help bring that down. But there's a lot of things that we'd have to work on. And so really for him, finding out what he's willing to start working on. I think, Kevin, you would agree, and you'll probably talk more about this, but his weight, if he has that excess adiposity, which we know he does, helping him to reduce that excess adiposity is going to help really all of the things that we want him to achieve for goal. His A1C would improve, his triglycerides would come down, his LDL-C may decrease with weight loss, depending on, how that affects him. So I think it would be having a conversation where what his past history was, what he's willing to do now, really emphasizing small steps to help him really focus on reducing that excess adiposity, which then is going to help all of those parameters that I mentioned, as well as his fatty liver.
Great. And Mariana, any additional thoughts from you?
Yeah, I mean, Carol, I don't know if you touched on this, but maybe lowering the alcohol even further, I think could help too. Maybe something to think about. I mean, it is low, but the more the better.
Very good point. In someone with elevated triglycerides, any alcohol is going to tend to exacerbate that. So,
well, and
maybe we can go.
real quick, that's a very good point, because some patients may tell you in clinic their consumption is 2 to 3 servings of alcoholic beverages per week, but it may be more. So kind of looking for maybe indication that is a conversation that needs to be had to kind of tease out whether they're actually consuming more alcohol than they're telling you.
Sure.
Yeah, that's a very good point. We usually, whatever the patient tells us, we assume it might be twice that much. So, if we go to the next point, the next question. So we've got some work to do with regard to lipids. We've also got some work to do with regard to diabetes control. And so would you make any medication changes? So Gregg, what's your first thought about the first place to go with regard to medication changes?
Well, I would divide that between diabetes and lipid management. So from a diabetic standpoint, this guy has a GLP-1 agonist written all over him, because the GLP-1 agonist, we're going to reduce cardiovascular risk, we're going to reduce weight, we're going to get his A1C down. And I don't know if we have time to go into this, but there's some evidence that we can actually reverse some of the steatosis. I forgot to mention earlier that the FIB-4 index can be used serially to track these patients. There's some limited evidence to support that, and I have certainly seen the FIB-4 index shift dramatically once we treat people with diet, lifestyle, and medication. So I'm thinking GLP-1 agonists. Then from a lipid standpoint, I think what I did with this guy, he is a reduce-it trial person, other than his elevated LFTs. So you put this guy on IPE. Are we sticking with generic names here, I guess, Kevin?
Yes,
yeah.
ideally,
so,
yes.
Right. So if this guy is an IPE candidate in the reduce-it trial, there were dramatic reductions in morbidity and mortality in a patient exactly like this, on a statin, diabetic, evidence of ASCVD, trigs above 150. I mean, I think we might get the most bang for our buck in terms of number needed to treat by putting the patient on IPE. And
yeah,
go ahead. No,
well, I was just going to make a comment. So the first thing you said about GLP-1 receptor agonist, I think, is really important, because that's going to induce weight loss and help control the diabetes. And if you get more than about 10% of body weight loss, you start to see reductions in fibrosis as well as hepatic fat. Yeah. And of course, we just recently had the results from the SELECT trial published, showing that even though the weight loss was a little bit less than 10%, it was about 9% in patients who had overweight or obesity plus ASCVD, there was a 20% reduction in major adverse cardiovascular events. I'll point out one more thing, which is that NASH and NAFLD are associated with chronic inflammation, and weight loss is one of the best ways to reduce inflammation. So just want to emphasize that a GLP-1 receptor agonist is a very reasonable place to go with a patient with these characteristics.
I'm not sure if you said this, Kevin, but SELECT was with a tirzepatide, right?
No, SELECT was with semaglutide.
Oh, it was semaglutide. Okay, I'm wrong. Right. I didn't know.
And there is a trial ongoing with tirzepatide, so stay tuned for more results.
Okay.
Yeah. And so maybe we can go to the next question here, because it's related. Would your management differ if the fibrosis was a little more severe, an F2 instead of an F1?
Well, I think the guidelines are more geared to in the three organizations that you pointed out, are more geared towards specific intervention with things like pioglitazone or GLP-1 or SGLT2 inhibitor, all of these things once you get to F2. So it becomes sort of like a judgment call. Are we going to wait until we get to that? And this is where I think, a clinician discretion is important. I think we had a slide in here somewhere, and we cut it out in the interest of time, where one of the guidelines said, F2 is where you start kicking in medication. There's no FDA approved medicine to reverse fibrosis. So we're doing all of this off-label based on pathophysiology and anecdote.
Right. And so, essentially management of cardiovascular risk and management of diabetes in someone who isn't at the F2 level is kind of standard care for
Right.
those other issues. And then once you get to the F2 level, then the recommendation is to consider pioglitazone, consider a GLP-1 receptor agonist, because those are going to really help to get at the fibrosis, particularly with weight loss. And so the challenge is with pioglitazone, you may get some weight gain, even though you get improvements in measures of liver function and fibrosis. But with a GLP-1 receptor agonist, you tend to get weight loss as well as improvement in steatosis and in fibrosis.
I
And
believe I have the slide that Gregg is mentioning, if you don't mind if I go
I
forward.
was,
Sure.
you read my
Cool.
mind. I was just going to say, maybe we can bring up that slide. Yeah.
So this is not necessarily what he was just mentioning, but I believe it was.
This is it.
This is the one.
Yes,
Yep.
absolutely. And this is an NLA slide, right? I think. Yeah, it is. Great.
And so again, with fatty liver or minimal fibrosis, it's just standard of care. But once you get to the F2 level of fibrosis, then you start to get into liver-directed pharmacotherapy and with more emphasis
Right.
on pioglitazone and GLP-1 receptor agonists. Any comments about use of vitamin E?
There's some data, Carol, isn't there, that 800 units of vitamin E per day, I don't know if it was, it helps to reverse the steatosis component, not fibrosis, but the GI guys I talk to aren't very excited about that anymore, and maybe just because they're more excited about new drugs in development. But can you tell us anything about that, Carol?
So Kevin and I were just speaking about a study, which I think Kevin can share more detail than I can. He was more familiar with the study, and it was only done in patients without diabetes. Is that correct, Kevin?
Right. So the recommendation is that vitamin E, high dose vitamin E, may be a consideration for patients without diabetes. And so in patients with diabetes, it's generally, the guidelines do not recommend use of vitamin E. So it's something to consider, but it should be considered again for patients with NASH who do not have diabetes. And
Kevin, can I point out one more thing while we're on this
Sure.
slide before we go? So, regarding the early use of GLP-1 agonists, realize, it is standard of care in ACE guidelines to potentially use a GLP-1 agonist whose hemoglobin A1C was what, 7.8? Does anybody remember? I think that's what it was.
7.6.
Right. So it would be
7.6.
well within standard of care. We have many choices for our standard of care now. And if anybody here is a Ralph DeFranzo fan, like I am, I mean, Ralph would immediately savage this case and say, why is this guy on metformin? Metformin does nothing for hepatic steatosis as opposed to some of these other agents where we have evidence for pioglitazone, where we have evidence for GLP-1s and SGLT2 inhibitors. So we have many choices under the standard of care banner. That's what I wanted to say.
Yeah, Ralph starts every newly diagnosed patient on triple therapy. And
Right.
so he
Right.
may include metformin, but it's always pioglitazone, a
Right.
GLP-1 receptor agonist, and either metformin or an SGLT2 inhibitor. And so, he's very aggressive, but his objective is to deal with the underlying issues of insulin resistance and pancreatic beta cell dysfunction. And then, you also get some metabolic benefits on other risk factors as well. So maybe we can talk a bit more about weight loss, because weight loss is going to be critical for this person. And Carol, I wonder if you can bring up the slide that shows the pyramid.
I can, but I do before I go forward, because I'm in control of the slides. I just want to emphasize that at every stage, because we're talking about pharmacotherapy, but as Gregg mentioned earlier, utilize the healthcare team. This patient, clearly previously had some education and for whatever reason kind of dropped off from that. And I think it's important for us to remember that patients need that support. So even when we add pharmacotherapy, to not forget about emphasizing lifestyle intervention, especially because that will help with this person, as they move forward. Our goal is to keep the weight off, and we all know how challenging that is. And so having that healthcare team and really emphasizing lifestyle intervention all along the way is just what I really want to emphasize as we move forward. And here is your pyramid.
So just a point to emphasize, and then I want Carol to weigh in with regard to, how you work with a person in terms of lifestyle to get the weight off and to keep the weight off. But again, with regard to both, well, with cardiovascular risk, diabetes control, and liver health, weight loss is one of the best things that can be done metabolically. And so Carol, maybe you can comment some more on working with patients to help them lose weight and maintain that weight loss with or without pharmacotherapy to assist that.
Okay, so I think we do have a slide that really does emphasize, obviously I'm going to be a proponent of lifestyle intervention first and foremost, but we do all have patients who struggle with, once they've had the weight, and really specifically talking about excess adiposity. So, emphasizing that we want the fat weight to come off, and really promoting, not just focusing on weight, but improved body composition. So lifestyle intervention can work, but even in the best efforts, a lot of patients get about 8% of their body weight reduction. And so that's where, and I think we do have a shift in thinking that for some patients, in addition to an intensive lifestyle intervention. So again, always the foundation of that intensive lifestyle intervention, adding pharmacotherapy can be helpful to patients for that success. Even with pharmacotherapy, long-term, it's important to emphasize behavior change. If anyone's tried to achieve any kind of behavior change, it's very difficult. So really, again, emphasizing the importance of providing support to patients, continued support with education. There's really some comprehensive programs that are available. And there's some research that shows if we can figure out ways using apps to touch base with patients more frequently, or doing more frequent visits with telehealth or phone calls, that really increases a patient's likelihood of success. That, more frequent intervention and contact with people to help them problem solve, help them work through the challenges that they're having with their improving their eating habits, increasing their activity. There's a lot that people have to do. So I think if we can provide support, whether that's through specifically lifestyle intervention, frequent visits, frequent touching base, adding pharmacotherapy as needed, and then for some patients, a bariatric surgery in addition to that lifestyle intervention may be an option.
And maybe you can comment further on the role of exercise and type of quantity and type of exercise in helping with weight loss and weight loss maintenance.
So for patients who are looking, or people who are looking at reducing their excess adiposity through physical activity, from my understanding, what the research shows is if you're only using physical activity, one, you have to have a higher amount of aerobic activity than what is recommended in our minimum 150 minutes per week. So if we're looking at reducing excess adiposity, it may be, minimum 200 to 300 minutes per week of moderate to vigorous intensity activity. But even with that, people may not see a dramatic decrease in their weight. So nutrition really is important. It has to be both for that kind of higher amount of weight reduction, specifically reducing adiposity. Comment?
Well, I was going to suggest also resistance exercise is very helpful to reduce the loss of lean body mass with weight loss. And Mariana, I wonder if you have a comment on weight loss and exercise and lifestyle for a patient like this.
Yeah, I mean, I think something that comes to mind, having done nutrition counseling, is also thinking about work and the social situation. So I've in clinic had patients who do construction and are really active, but then the lunch breaks are really tight and they only can get fast food nearby, or some patients who are working a desk job. So I would think about that as well, for him in the home life, who's cooking the meals, etc.
Very good point. I'll use Al Brown's line here too, which is discipline is important for weight loss, but the trouble with discipline is it has a half-life of 2 weeks and it's soluble in alcohol. So
Excellent.
That's a challenge. Maybe we can go back to the questions slide.
Hey, Kevin, can I say one more thing about exercise? I don't
Absolutely.
remember who I learned this from, but muscle is hungry. That's what I tell patients. Muscle is hungry. You've got to build and maintain muscle to improve your insulin sensitivity, because muscle, and the patient says muscle's hungry for what? It's hungry for all of these bad things, inflammatory factors, sugars, triglycerides, all of this stuff. Muscle is hungry. You've got to build muscle. And then I also tell patients, look, you don't want to fall and fracture your hip when you're 80 years old or 85. That's how many of our parents go out of this world. And, so you have to improve your strength and maintain it, to reduce the risk of falls when you're older. So those are a couple of ways. And one other nutritional thing, I'm sure Carol knows this one, but I tell patients, look, when you drink sugar, particularly, fructose containing drinks, I tell patients your liver screams. You can't hear it, but I can when I look at your liver function test. And many patients pause when they hear that. Is drinking fructose is just the worst thing you can do in terms of interfering with mitochondrial function and laying down triglycerides in the liver and stuff. I'm sure Carol would agree with that. So we got to get people to stop drinking sugar.
Well, and I mean, fructose for sure is going to definitely influence triglyceride production in the liver, but
Right.
really excessive amount of any kind of added sugar is going
Right.
to be a good thing. So
Right.
definitely talking with patients about healthier beverages, healthier choices with food overall. I just want to put in terms of physical activity, a well-rounded physical activity routine is endurance activity, strength training 2 to 3 times a week, and flexibility, because if people are not flexible, that can also increase the risk for injury, and then they're not going to be physically active, and it kind of starts a really negative spiral. So talking about all of the benefits of physical activity in the different aspects, and not just for weight reduction, but obviously it's going to improve all kinds of cardiometabolic risk factors.
And just a comment about physical activity, and particularly aerobic activity, but it also applies to resistance exercise. And the American Heart Association just put out a statement about resistance exercise and cardiovascular health. So I recommend reading that. But what I tell people is there are 2 components to the benefits of exercise. There's a chronic component that relates to body composition and some of the metabolic benefits of the exercise, but there's an acute component. So when you exercise for 30 or 60 minutes, insulin sensitivity is improved for a period of 24 hours or a bit more. And so what I tell people is, if you stop taking your statin, your cholesterol will go up. Well, if you stop exercising, then you'll see your insulin resistance going up. And I tell people that you can think of exercise as being like a pill that it takes at least 30 minutes to swallow. So,
Like that.
Great. We talked a little bit earlier about statins, and I just want to emphasize this point and get everyone to comment on it. Lots of clinicians are concerned when they see someone with elevated liver enzymes about a patient being on a statin, starting a statin, or often they will discontinue a statin if they see the liver enzymes elevated, when most often the elevation in liver enzymes is not related to the statin. So Gregg, maybe you can comment on that. You said it earlier, but I want to emphasize this point.
Yeah, because one of our 2 primary objectives in these patients is to reduce cardiovascular risk. Obviously, statins are the bulwark of what we do with that. And there is actually some long-term data that if you take somebody like this with elevated liver function tests and put them on a statin, their LFTs may bump up a little bit initially, but they will often go down in the long run. And there's some evidence that the FIB4 index will improve on a statins. Statins reduce inflammation in the liver. They reduce the percent fat. Fiber scans may improve on statins. So statins do a lot of very interesting and positive things. And I think we have to look at the trajectory of the liver function test. Obviously, if you put this guy on a statin, he's already on one, and his LFTs jump to 300 immediately, obviously we're going to throttle back, and maybe we won't go there. But I think we just have to realize how important the statins are for these patients.
And then also earlier we mentioned that we'd like to see that non-HDL cholesterol level down to less than 100 in this patient because the person's at high cardiovascular risk. And so person, as I remember, is already on a statin plus ezetimibe. So what additional pharmacotherapy might be considered beyond a GLP-1 receptor agonist and other drugs to manage the diabetes on the lipid side? What would be your thoughts there? Gregg?
Yeah, for me, it certainly would be IPE, like I might have mentioned before, because we have tremendous evidence from the REDUCE trial in exactly this kind of patient that we're going to reduce morbidity and mortality in this kind of patient. The number needed to treat is quite low in this type of patient, in the 20s. So yeah, that would be the first thing I would think of. I guess you could do it sequentially and see what Carol and plus or minus GLP-1 agonist would do to him first. His trigs might come down enough that you don't need the IPE, but meanwhile, you got a patient in front of you. I would tend to be aggressive and start the IPE and maybe withdraw it later if we don't need it.
And then what about things like bempedoic acid or a PCSK9 inhibitor? What would be your thoughts there for a patient like this?
Yeah, I would be all about trying to get his ApoB down lower, and certainly, like we said, getting his LDL cholesterol under 70. Bempedoic acid, we'd have to. Now, I don't have a uric acid on this guy, but anybody here want to vote that his uric acid is normal? I'm not taking that bet. Okay, uric acid, right, Kevin? His uric acid is probably, I should have put that in here. I have that data.
Yeah, if I had to guess, I would say it's likely elevated.
Right. So, so in case anyone's not clear on that, bempedoic acid certainly can elevate uric acid. It's one of its few metabolic bad effects. So that wouldn't be my first thought. PCSK9 inhibitor, would be potentially fantastic for this guy if we really want to get his ApoB down lower, his LDL cholesterol down lower. We might have some trouble getting it approved, because that could be, you have to finagle these subclinical disease indications sometimes to get approval for PCSK9 inhibitor.
Yeah, that would be a potential challenge. Yeah. And
right.
It's easier to get them approved now than it was a few years ago, but still not always, a slam dunk. And are there, so we haven't had any questions from the audience. We're going to wait and see if we get any of those. But in the meantime, I would like to, Carol, if you can go to the slide that shows the recommendations.
Not this one, but the summary of, okay. Sorry about the scrolling, everyone.
Yeah, so apologies for the.
Yeah.
So this slide emphasizes that, again, the drug classes for which we have direct evidence in NASH of liver benefit in terms of fibrosis and fat would be pioglitazone and GLP-1 receptor agonists. And then we don't have that evidence for the other diabetes drugs. Again, for vitamin E, we have some evidence for treating people without type 2 diabetes, and other pharmacotherapies may be useful to manage cardiovascular risk factors and diabetes, but again, not any specific recommendations for those in NASH. And then maybe we can go to the next slide. And then with regard to weight loss, as we've already mentioned, that improves all of the cardiovascular and diabetes factors, as well as having favorable effects on the liver. And so these are the recommendations with regard to lifestyle modification and then chronic weight management, with, again, for selected patients, bariatric surgery being an option. Now, the newer drugs are starting to approach bariatric surgery in terms of the degree of weight loss. And so that's also something to think about, particularly tirzepatide, as we mentioned, and there's another drug in development that's a G3 drug. So glucagon, GIP, and GLP-1 receptor. And that's producing weight loss that is basically equivalent to that with bariatric surgery. Gregg, do you want to comment on, if or how often you recommend referral to for consideration of bariatric surgery?
I don't recommend it enough, Kevin. I mean, I honestly don't. I mean, for the patients who are obviously either refractory to some of these other treatments, but what I thought you were going to ask, Kevin, and maybe you had this in mind, when do we refer to a hepatologist? Did you want to come to that? Because we only have a moment or two.
So
sorry.
that's you read my mind.
Yeah.
Then, at what point do you bring a hepatologist into the treatment plan?
Once you start getting into more advanced fibrosis, like particularly the F3 category and F4, I mean, that is most certainly when you want to do it, because there are some clinical trials out there that that my gastroenterologists have access to for people with advanced fibrosis. So those are it just depends on your comfort level. Some clinicians will say anybody with F2 and above on a fiber scan you should send. But I think most of us as cardiometabolic experts here feel comfortable maybe with treating those earlier patients with drugs like pioglitazone and or a GLP-1 agonist. But that's the basic outline.
Okay, we've got just about 1 minute before Merle will wrap things up. And so any additional comments from Carol or Mariana?
I think we've done a nice job emphasizing the importance of lifestyle intervention. So, and I do know that all of the recommendations that Kevin mentioned at the very beginning do provide further recommendations for lifestyle interventions, nutrition and physical activity, as well as obviously the NLA does. So I would encourage people to use those recommendations.
Great.
Well, thank you everyone for your contribution tonight, our panelists, our presenter, and the NLA staff for supporting this activity. Again, if you have ideas for future lipid panels, we'd love to hear about them. Any other questions, comments, or suggestions, please send them in. Again, thank you to our panelists and to our presenters. Have a good night and happy holidays to everyone.
Take care.
Happy holidays, everyone.
Yeah, you too. Take care.